Good morning. Today's topic is breast histology and applied anatomy. Applied anatomy is defined as the application of anatomical knowledge in the diagnosis and treatment of the disease. Breast or mammary glands are highly modified apocrine sweat glands. They develop along the milk line of Schultz, which extends from the axilla to the groin. Normally, only one gland develops on each side of the thorax. However, due to anatomical variations, numerous glands or accessory glands or nipples may develop. The development of accessory nipples is called polythelia, whereas the development of accessory glands is called polymastia. In both the genders, the development of mammary glands is same until puberty in female glands, where the development of mammary glands is under the influence of pituitary, ovarian, and other hormones. In every month, the breast undergoes cyclical changes in activity due to the hormones of the ovarian cycles. After menopause, there is progressive atrophy and involutional change. The breast lies in the superficial fascia of the pectoral region. It extends from the second rib to the sixth rib. It is divided into four quadrants. There is also an axillary tail of spence which passes through an opening in the deep fascia called foramen of Langer and lies in the axilla. The four quadrants are called as upper outer or superolateral, upper inner or superomedial, lower outer inferolateral or lower inner or inferomedial. Then we are also supposed to know the four boundaries of mastectomy, which is important for the surgeon while the resection of specimen during the cases of breast carcinoma. The superior border is the clavicle. The inferior boundary is the inframammary fold. The sternum midline is the medial boundary, and the anterior border of the latissimus dorsi is the lateral boundary. Here we can see a mastectomy specimen. We frequently get mastectomy specimens in our histopathological section, where we are attached a superior string for the superior border and the long string for the lateral border. These markings are given by the surgeon for us to clinically orient the specimen. As we can see, the nipple and areola is shifted towards one side because of the tumor present here, and we can also see the tumor from the base here. The deep surface of the breast is related to the following structures. First is the loose areolar tissue called the retromammary space, the pectoral fascia covering the pectoralis major, and parts of the following three muscles: the pectoralis major, the serratus anterior, and the external oblique. The importance of this space is that when the breast is freely moved around this space. If there is no free movement, then the carcinoma or the tumor has involved the deeper tissues. The skin of the breast has two special structures, the nipple and the areola. The nipple is present just below the center of the breast at the level of fourth intercostal space. It is pierced by 50 to 20 lactiferous ducts. It has a few modified sweat and sebaceous glands. The pigmented skin surrounding the base of the nipple is called the areola, which is rich in modified sebaceous gland. These modified sebaceous glands become enlarged during pregnancy and lactation to form raised tubercles of Montgomery. The tissue of the breast is divided into two parts, the parenchyma and the stroma, of which the parenchyma is composed of glandular tissue. The morphological functional unit of the breast is a complex branching structure that is topographically arranged into 15 to 20 lobes, which corresponds to the 15 to 20 ducts in the nipple, and which is made up of two major components, the terminal duct lobular unit and the large duct system. The large duct system and the terminal duct lobular unit. The terminal duct lobular unit represents the gland secretory part. The terminal duct lobular unit then continues as a subsegmental duct, which then continues to segmental duct, and then collecting or lactiferous ducts, which then opens up into the nipple. Just before the opening up into the nipple, there is a fusiform dilatation, which is called as a lactiferous sinus. The other part of the structure, internal structure of the breast is the stroma, which is partly fibrous and partly fatty. The fibrous part of the stroma is formed by suspensory ligaments of Cooper, which anchor the skin and the gland to the pectoral fascia. This is important in the part when it is involved by the cancerous lesion. It pulls along this fibrous stroma and causes dimpling or puckering of the breast. The fatty stroma forms the main bulk of the gland and is distributed all over the breast except beneath the areola and the nipple. When a patient presents, the patient can present with many of these changes, like the redness of the skin around the nipple and areola can be due to mastitis, which is a benign condition, or can be due to a malignant condition in inflammatory carcinoma. Then there can be a lump in the breast which may or may not displace the nipple or areola. The lump can be benign or malignant. If the lump is increases in size, then the patient may not complain as of a lump, but it can complain of the total swelling of the breast. Sometimes the patient does not present with a lump or swelling in the breast, but there is presentation of lump in the armpit, which can translate to the metastasis or primary tumor in the lymph node in the axilla or in the axillary talus pens. Then there is orange peel texture, which is characteristically seen in the carcinoma, in which the carcinoma involves the superficial lymphatics in the skin. The dimpling, as described earlier, is due to involvement of the tumor to the suspensory ligaments of Cooper. There can be various types of changes in the nipple also. The nipple can have discharge, which can be of various colors described subsequently. There can be pulling in, which can be due to fibrocystic disease, or it can be due to ductectasia, or it can be due to involvement of carcinoma. The changing direction of nipple can be due to underlying tumor as seen earlier in the specimen shown. There can be ulceration or scaliness of the nipple and areola, which is characteristically seen in Paget's disease. Then these are the various types of discharge seen from nipple. The discharge is clear, seen in mammary duct ectasia. It can be milky, is normally due to breastfeeding, or it can be due to galactorrhea. If it is yellow, then it signifies infection. It is green it is green in fibrocystic disease. This is brown in mammary duct ectasia as well as fibrocystic disease. However, if there is a bloody discharge, it can signify intraductal papilloma. The mammary gland is extremely vascular. It is supplied by the following arteries: perforating branch of the internal thoracic artery, lateral thoracic artery, superior thoracic and acromiothoracic arteries, lateral branches of the posterior intercostal arteries. The vein follows the arteries and run in superficial and deep sets. The superficial veins drain into the internal thoracic vein and superficial veins on the lower neck. The deep veins drain into the axillary and posterior intercostal veins. Through these veins, the tumor may be reached to the vertebra to the Batson plexus. The knowledge of lymph nodes is very important as far as the operative as well as the grading is concerned, as the breast carcinoma frequently spreads to the other breast as well as other parts of the body through the lymph nodes. Lymph from the breast drains into the following lymph nodes: the axillary lymph node groups, which are the anterior, the posterior, lateral, central, and apical. The other groups of lymph nodes are the anterior thoracic lymph nodes, supraclavicular lymph nodes, cephalic, that is deltopectoral lymph nodes, posterior intercostal nodes, subdiaphragmatic and subperitoneal lymph plexuses. The quadrants which we have studied earlier have typical drainage system into usual groups of nodes. For example, the upper outer quadrant drains into the supraclavicular. First, it drains into the anterior posterior axillary nodes and then into the supraclavicular nodes. The upper inner drains into the internal mammary nodes and then to the supraclavicular nodes. The lower outer quadrant drains into posterior intercostal nodes and subdiaphragmatic nodes, and the lower inner quadrant drains into internal mammary nodes and subdiaphragmatic nodes. Then there is a surgical classification of lymph nodes, which is done on table. A simpler classification is used to describe breast nodes recently as per relation to pectoralis minor. Those lying below pectoralis minor are level 1 nodes. Those behind the muscle are level 2 nodes. Those between the upper border of pectoralis minor and lower border of the clavicle are level 3 nodes. The next important topic is sentinel lymph node biopsy, the most common way to check the axillary lymph nodes for cancer. In this procedure, a radioactive substance called a tracer or a blue dye is injected into the breast, which helps the surgeon in finding the nodes to remove. The first lymph node to absorb the tracer or dye is called the sentinel node, where the breast cancer is likely to spread. If the biopsy of this node comes positive, this signifies that there is extensive requirement of increase the margin is insufficient and the tumor needs to be resected extensively. After removal of the sentinel node, it is examined for malignancy. Understanding the lymphatic drainage of the breast is of practical importance in predicting the metastasis of breast cancer. As seen earlier, this is the orange peel of Pyade orange appearance. It is due to the involvement of superficial lymphatics. The superficial lymphatics drain the skin over the breast except for the nipple and areola. The lymphatics pass radially to the surrounding lymph nodes, axillary, anterior thoracic, supraclavicular, and cephalic. The deep lymphatics drain the parenchyma of the breast, but they also drain the nipple and areola. The breast lymph node is mostly to the axillary nodes amounting to 75%, 20% to anterior thoracic nodes, and 5% to posterior intercostal. The internal mammary nodes are important as they cause communication between the two breasts. So the tumor in one side of the breast can get transferred to the opposite side through these internal mammary nodes. The microscopic structure of the breast is defined under the same three headings which we were studying the gross anatomy of the breast, which is the skin, parenchyma, which is composed of the epithelial glandular tissue of the tubular alveolar type, and the stroma, which is made of fibrous connective tissue and fat surrounding the glandular tissue. Here we see the histology of the nipple. Here we can see the epithelium, which is stratified squamous type. There is a sebaceous gland, which open independently of the hair follicle, as the nipple and areola are devoid of hair. Here we see the large ducts and the fusiform dilatation of the called the lactiferous sinus. A dense fibrous stroma in which erectile smooth tissue is embedded. Then we see the histology of the terminal duct lobular unit. The glandular tissue is formed of two parts, the terminal duct lobular unit and the large ducts. The terminal duct lobular unit has a distinct lobular architecture, presence of specialized myxoid appearing hormone responsive connective tissue, presence of specialized inner epithelial cell layer with secretory and absorptive functions surrounded by myoepithelial cell layer. This is important as the presence of these two cell layers signifies the benign nature of any lesion which may arise from the breast. This also has absence of elastic fibers which is present significantly in the around the large ducts. Here we can see the terminal duct lobular unit, which is inside it is lined by epithelial cell and outside by myoepithelial cell. There is present deficiency of elastic fibers and surrounding fibrofatty collagenous tissue. On high power, we see that terminal duct lobular unit, the acini, are lined by two types of cells, the epithelial cells and the myoepithelial cells, which are signified by, which are seen characteristically show large spaces. In the specimens that we receive, it is very important that these two cell types are sought for. These two cell types, if present together, signify that the tumor is of benign origin. For epithelial cells, the markers used are epithelial membrane antigen (EMA), mammaglobin, GCDFP15, GATA3 GATA3, cytokeratins 8, 18 and 9. In this photo, we see that the mammaglobin stain is used. The markers for myoepithelial cell are high molecular weight HMW cytokeratins, smooth muscle actin SMA, salponin, smooth muscle myosin heavy chain, maspin, aldosmon only in the ductal portion, nuclear reactivity for P63, a member of TP53 gene family, P75 neurotrophin receptor, cytokeratin 14. As the myoepithelial cell functions to squeeze out the secretions into the larger ducts, the markers have similar characteristic to the muscle cells. Then there is a stromal histology. The glandular parenchyma is surrounded by fibrofatty stroma comprising of type 4 collagen and adipose tissue. Here we see the adipose tissue interlined by and surrounding fibrous tissue. Here we see a large vessel. The physiological changes in breast as per the age show different histological appearances. Breast tissue responds to hormone and other stimuli throughout life. The different appearances at various stages of life can be described under the following subheadings. Pre-puberty, non-lactating stage in reproductive age group, pregnant and lactating stage, and postmenopausal stage. In prepubertal stage, the breast tissue is largely immature and in the resting stage. This is described as the stromal part being more dominant and the terminal duct lobular unit being very immature. However, post-puberty, due to the response of hormones, there are many different changes which also are different as per the stage of the menstrual cycle. In reproductive age group, there are changes corresponding to the phase of menstrual cycle. Proliferative phase, follicular phase, small lobules with few terminal duct, small acinar luminae, rare mitotic figures, condensed intralobular stroma. Myoepithelial cells inconspicuous, absence of inflammatory infiltrate in the intralobular stroma. In the secretory luteal phase, there are larger lobules, more terminal duct structures, open acinar lumina, prominent apical snouting, stromal edema, which is felt by the subject as breast fullness, and increased mitotic figures. Myoepithelial cells with prominent cytoplasmic vacuolization, mixed inflammatory infiltrate in the stroma. In perimenstrual breast, the acina lumina are very distended with secretions. Luminal cells with scant cytoplasm and less apical snouting. Myoepithelial cells with extensive cytoplasmic vacuolization and increased inflammatory infiltrate in the stroma. During pregnancy, as the breast prepares for its postpartum function of lactation, there is increased proliferation which leads to increased number of secretory acini under the influence of estrogen and progesterone. Here we see the increased number of acini in the lobule which is separated by the fibrocollagenous stroma. During lactation, the levels of circulating progesterone and estrogen which inhibit milk secretion fall precipitously. This leads to increase in the number of lobules and subsequently acini, and the intervening stroma, which is fibrous fatty, is reduced to a very thin structure due to the function of lactation. There is increased the secretions can be seen in the acini. Whereas changes in menopause. In postmenopausal, terminal duct lobular unit may acquire a microcystic quality with deposit of elastic tissue around the ducts known as elastosis. The increase in stromal component and the terminal duct lobular unit becoming somewhat like a microcyst. We then move on to very common conditions seen in the breast. The first is a fibroadenoma, which is a benign biphasic tumor. It is called biphasic because it has an epithelial component and the stromal component. In this, there are two types called intracanalicular patterns and the pericanalicular pattern. In the intracanalicular pattern, the stroma increases and compresses the drug into slit-like glandular places, whereas in the pericanalicular pattern, the stroma arranges itself in concentric circles around the ducts, but the ducts are not compressed. This is a phylloid tumor which can be benign, malignant, or a borderline tumor. It has leaf-like arrangements, hence it is called phylloids, which is in Greek for leaf-like. It is characterized by increase in the stromal component. The stroma, as we have seen already, is composed of fibrofatty tissue. The fibrocystic disease of breast, which consists of three components, there is increase in the stromal component, there is increased adenosis, and some glands dilate enough to form cyst-like structures, the cystic appearance. Then we see carcinoma of breast, in which we see that the arrangement of the normal TDLU pattern is not seen. However, the malignant cells arrange themselves in a single file called Indian file pattern. So this is seen in invasive lobular carcinoma. However, in invasive ductal carcinoma, the malignant cells arrange themselves in the form of the duct. The cells we see have increased chromatin appearance, and there is difference in size, also known as pleomorphism. The nuclear to cytoplasmic ratio is high. As we can see, the nucleus have increased in size. So these changes can be compared to the earlier normal histological features seen in the breast. These are my references for this presentation.